Very good afternoon, all. I welcome you all to the webinar series on COVID, and this is a part 3 of our webinar series. And this is presented by the Clinical Infectious Disease Society, CIDS. And we had an overwhelming positive response and feedback to our initial part 1, part 2 of our webinar series. And to go with that, we have come up with a newer version. And with this, we are looking into debates, discussions on areas in which there is lack of clarity. And of course, the lectures that were earlier designed to be 30 to 40 minutes, we made it even more shorter this time so that it is much more crisper. And we have had a change in the program format, and people who join in through the Zoom webinar, it will be limited to the initial 500 participants, and people who join in late can always watch it live on the YouTube link. And all we have to do is type CIDS webinar in the YouTube, and then you would have access to the live action. And then all these videos are put up in our website, www.sidsindia.org, and as well as you could access the content with respect to the current one, plus the previous 2 editions too, from the CIDS website or from the YouTube channel. And to go on with our presentation for today, we have Dr. V. Ramasubramaniam as the moderator, plus he would be also giving the lecture on infection control in outpatient clinics and standalone clinics or in the outpatient scenario. I think now all of us are gearing up to be back into practice. That is something that we should be aware on how to protect ourselves, plus other patients, plus our secretarial staff in our outpatient clinic. And then we have a debate, and the debate is on to decide on what would be an appropriate mask in this COVID era. Should we go for the N95, which is currently favored by most of the doctors? To talk on it, we have Dr. Surabhi Madan from Ahmedabad, who is an infectious disease physician practicing at Ahmedabad. And then to go for the surgical 3-ply mask, we have Dr. Vinay Devraj, who is again an infectious disease physician who trained with us at Apollo Chennai. Right now, he is a consultant in infectious diseases, plus he takes care of the infection control at Apollo Hospitals, Bangalore. And with this introduction, we would start today's session, and I hand over the mic to Dr. V. Ramasubramaniam. I don't think he requires any introduction. Most of the clinicians or physicians in India would know Dr. Ramasubramaniam. He is one of those pioneers in the field of infectious diseases and infection control, and he practices at Apollo Hospitals, Chennai, and he is a doyen in the world of infection control. Off to him. Thank you.
Thank you very much, Dr. Nambi, for those very kind words. And I shall start my program. We are right now at the crux of change, where the lockdown is hopefully going to be lifted. The government has already encouraged that we probably look at starting our clinics. I hope you can see my screen.
Yes, Doctor.
Yeah, okay. Now, see, we are trying to be as ideal as possible in our approach to protecting ourselves and our patients. So I would like to start my slide as saying that when we try to be ideal, there are certain requirements which may not be practical in real life. You know, I'm sorry, my screen is not moving. I'm just going to just give me a minute. Can you see my screen now?
No, sir.
Yes.
Now?
Yeah,
Yes,
it is coming. Yeah.
Yeah, okay, I'm sorry for that confusion. So we are, as I said, we are looking at a situation where we are looking at an ideal scenario where we need to protect ourselves, but practical scenarios may be different. Oh, I'm really sorry, my slides are not moving. Just give me another minute. Can you see my screen now?
not yet.
Not yet. I'm going to close it and open it again. Just give me 1 minute.
Sir, if needed, I'll share it from here, doctor, and I'll give you a remote control access.
Yes, please. I think there's some, it's not moving forward when I move.
I'll do that.
Yeah, please.
One moment, sir.
I apologize. There's some confusion in my slides moving forward.
Doctor,
Yeah, so we are. Yeah.
You can access from there. Use the mouse, doctor.
Okay, should I share the screen now? Should I?
No. You can just scroll down. I have shared the screen.
I'm not able to move it forward. No, can you move it for me? Yeah. Okay, I'll just ask you to move the slides. I'm sorry, because already we are running about 3 minutes late. So this happens to be the client requirements, as we say that we are looking at a situation where all of us have N95 masks, all of us have coveralls, all of us wear, the appropriate face shield. But unfortunately, when we look at the budget of standalone clinics and looking at HEPA filters and, protocols in place and, the size of the rooms and waiting areas, I think the budget does not, allow us to deal with the requirements. Next slide, please. Next slide, Shabina. Yeah, so in disclosures, next one. I realize in a crisis like this, there are no solutions, but what I would refer to as only trade-offs, in the sense we need to trade off ideal situation with a practical situation to ensure that there is protection and comfort. So my beliefs in this presentation for the next 10, 12 minutes or so would be comparing what is ideal versus practical, and I lean towards the practical side. We need to ensure that we are comfortable at work, because only if we are comfortable, we can adhere to infection control practices. We need to educate ourselves to see how things are moving forward. And most importantly, we need to discipline, next slide, ourselves in this situation. I have no conflicts of interests. Next slide. So this is the slide I showed in my earlier presentation, the standard precautions. WHO's 5 moments of hand hygiene is still the basic block, fundamental block on which the entire process of infection control is based on, which means whenever you are touching the patient, whenever after touching the patient, before a procedure, after a procedure, and after touching the patient's immediate environment, we need to use hand hygiene or wash our hands. Use soap and water if the hands are visibly soiled, otherwise an alcohol solution 60 to 95% if they are not soiled. And we need to, most importantly, learn to use the personal protective equipment correctly and dispose them off correctly. Next slide, please. The new normal, as we can see, this is the recommendations for all clinics, which will involve, if the patient calls for an appointment, screen the patient by phone to decide what kind of symptoms he has and delay routine or non-urgent visits till symptoms settle. Consider using telemedicine, which a lot of people are using, but the patients somehow are not very happy, at least the older generation, in this mode of consultation. Recommend home care with symptom monitoring without face-to-face evaluation whenever, after talking to the patient, you think it is clinically appropriate. Consider alternative routes of entry and exit and waiting areas, which may not be practical in most clinics which are currently existing. Implement respiratory hygiene and cough etiquette, especially signages, so that the patient are aware of what they need to adhere to. Surgical or procedural masks should be readily available to all people, both healthcare workers and patients at entries and exits with a clear signage, and limit the number of patients in the lobbies or waiting rooms. Now, the government has encouraged what is known as fever clinics to ensure that people who present with fever and who may have COVID are taken care of separately. So there is a separate area where they can be seen and a separate methodology and protocol to be followed. But in my practice in the last couple of months, I feel that this may not be practical because a lot of patients do not come in with fever. So when you ask them fever, they say they are feeling tired, they have headaches and they have body aches, and they may deny fever, in fact. And I've seen very clearly that in the patients whom we have diagnosed as COVID, 90% do not complain of cough. Either they don't want to say that they have cough, they deny symptoms of cough. So this doesn't make it practical to assess or screen the patient. And I often find that COVID presents in bizarre forms other than fever. So having fever clinics may not be optimal. You need to have a situation where all patients are treated as COVID positive and precautions are taken. Next slide. The first step in clinic approaches staff education, which means they need to be explained and educated about standard precautions, how to use the PPE, in what situations, how do you put them on, how do you doff them is very important. You need to cross-train your staff. A receptionist may sometimes have to ask screening questions and triage the patient. A nurse may sometimes has to act as a receptionist and take charge of the reception desk, because in case one member of your staff falls ill, there are other people to cover for the person. So you need to cross-train them. Healthcare practitioners need to self-monitor for symptoms. It is very important that all of us, the doctors, the nurses, the secretarial staff, all of them ideally check their temperature in the morning before they come to work. I realize that the guns, the non-touch guns, are not as sensitive as a thermometer. And we find a lot of patients who say they don't have fever, and with a thermal gun, they don't show fever. You walk into the clinic and they have a temperature of 101. So however sensitive the thermal gun is, it may not sometimes work optimally. You need to develop a plan for what the healthcare practitioner will do if they become symptomatic, either just before coming to work or after they come to work. So how do you manage them has to be written down in advance. And how self-isolation at home should be done in case they become symptomatic. All these have to be discussed with the staff. Next slide, please. If you look at educating patients, which come next, they should be told, even when the appointment is taken on the phone, what is the process of meeting the doctor, what are the points you need to keep in mind. In other words, when they enter the clinic, they should be insisted that they all wear masks. Hand hygiene should be given to all of them. Physical distancing should be encouraged. They need to be educated about quarantining and isolation. Now, since we are seeing an increased number of patients, admitting all patients in hospital is not practical. So those who are educated, those who can manage at home, should be isolated or quarantined at home. The importance of namaste versus handshaking, the importance of cough etiquette, hand washing, and environmental cleaning should all be educated to the patient. This is best done in the form of posters or signages, which you can put up at the entry to your clinic or even in the waiting area. Next slide, please. These are the standard recommendations from the World Health Organization. This came up on the 19th of March in their interim recommendations, that when you are dealing with COVID patients, for routine care, a face mask, an eye protection, or a face shield, gown, and clean non-sterile gloves are indicated. For aerosol generating procedures, you also need to wear an N95 mask instead of a surgical mask. And for collection of laboratory specimens, it's similar to the aerosol generating procedures. But these are for handling known patients who are COVID positive. How would you handle somebody who walks into your clinic? Next slide. These recommendations, next slide, please. These recommendations from the Ministry of Health and Family Welfare, which was updated just about a few days ago, is much more practical and tells us that if you have a secretary in the registration counter, she needs or he needs to wear a triple layer mask and probably latex examination gloves. And more importantly, physical distancing between the staff and the patient should be adhered to. In the doctor's chamber, the doctor doesn't need to wear a gown, visual face shield. The person essentially needs to wear a triple layered medical or a surgical mask and latest examination gloves. Please remember that you need to change gloves between each patient if you happen to touch the patient. If you are doing aerosol generating procedures, this will not suffice. And like for a dentist or an ophthalmologist or an ENT physician or an ENT surgeon, they need to wear an N95 mask along with face shield or goggles along with gloves is indicated if especially aerosol generating procedures are anticipated. In the pharmacy counter also, a triple layered mask and latex examination gloves are recommended. I personally don't routinely wear gloves. I ensure that whenever I come in the proximity of the patient or touch the patient, I immediately go and wash my hands, because remembering to take the gloves off, remembering not to touch your pen with your gloves, remembering not to touch your table or your pad where you're writing with the gloves is a little difficult for me. So I make sure that if I touch, I always wash my hands, but otherwise a pair of gloves is recommended. And more importantly, a triple layered surgical or medical mask. Next slide, please. If aerosol generating procedures are done, and what do you mean by them? Opening, suctioning of airways or tracheostomy, wounds, sputum induction, CPR, bronchoscopy, or dental work, or nebulization or high flow oxygen delivery, then you need to wear an N95 mask. Next slide. If you are keeping a room where nebulization is done, or you feel that any aerosol generating procedures may be done, you need to make sure that the room is well ventilated. Routine use of HEPA filter is not recommended as long as you're able to have a good ventilation of at least 160 liters per second, which means you can have an open window on one side, a fan on the other side, and make sure that the fan blows from the doctor to the patient to the outside, so that whatever aerosol is generated or sputum or whatever is generated is blown out through the window. Ideally 12 air exchanges. Now it is not possible in a clinic setup to do all this, but make sure that the ventilation is good enough. So even if you have the air conditioning on, make sure that the windows are open so that the fan blows it out. N95 mask, if you're using, make sure that you always perform a seal check, which means ensure that the mask is tight around your nose and around the chin so that there is no leakage. Eye protection is encouraged, and a clean, non-sterile long-sleeved gown is recommended if aerosolizing procedures are done. Next slide. If you're using a mask, please remember that the face mask should be removed and discarded if soiled, damaged, or hard to breathe through, or if it becomes wet. Healthcare practitioners must not touch the face mask. If you touch them or adjust them, you should immediately perform hand hygiene. HCP should leave the patient care area if they need to remove the face mask. And if you are using a face mask continuously, generally about 4 to 5 hours is a reasonably safe limit of usage. If it's an N95 mask, up to 6 hours you can use the mask before you take it off. And if you're looking at reuse, we are looking more and more at reusing. Just put it in a breathable, probably a brown paper bag after your use, and do not touch it for the next 3 to 4 days. If you take it out on the 5th day, it's perfectly fine. You can reuse it. But even when you reuse it, make sure that after you put your mask on, you wash your hands before you proceed with your other activities. Next slide, please. Now, this is the protocol for cleaning. This is again, which came about quite recently from the WHO on the 15th of May. You need to ensure that training, monitoring, audit and feedback, reminders, and signages are placed in your clinic to help those who are doing environmental disinfection. The cleaning protocol should be standardized. It is recommended that you clean from a least soiled area to a more dirty area, from a higher level to a lower level in case debris falls down, and always change your cloth if the disinfectant in that goes down. It is also ideally recommended that you color code the cloth for saying that which area it is used, so that you don't get confusion before it is reused. Now, the WHO has given a very nice, simple formula to calculate what is the how you dilute the bleach. The percentage of chlorine in the liquid or liquid sodium hypochlorite divided by the percentage of chlorine required minus 1 is what you should aim at. I will tell you what should be the percentage subsequently. Please remember that a contact time of a minimum 1 minute is recommended after applying the disinfectant before you remove it. And before you put the disinfectant, you need to clean the area. The disinfectant does not work if there is organic material present. So you need to clean the area and then use the disinfectant, leave for a minute, and then wipe it off. There is no routine use of spraying or fumigation. Even if spraying and fumigation is attempted, you need to manually clean the area before spraying is done. Next slide, please. The environmental disinfection, remember that the personal protective equipment is important for the staff who clean. For room cleaning, a detergent followed by 0.1% sodium hypochlorite. That is, if you're using a 5% solution of household bleach, 1 in 50 dilution is what is required, which equals to about 0.1% concentration. For surfaces that can be damaged by sodium hypochlorite, an alcohol solution of at least 70% is recommended. Toilets, again, it is 0.1%. Linen and mattresses, you can use 5% Lysol, and a 1% sodium hypochlorite solution should be used for cleaning floors and ambulances. Please remember that if you have blood spills, major blood spills, more than 10 ml of blood or body fluid spill, you need to clean it and use a stronger solution of 1% sodium hypochlorite before you let it at least 1 minute contact time, and then you remove it. Next slide, please. Unfortunately, this is Shabina, the slide I had sent is actually a little different. There was one more slide I had added on the frequency of cleaning. Basically, the frequency should be ideally for high-touch surfaces or those used by patients. Their patients' chairs or patients' equipment which are used should be disinfected between each patient use. Otherwise, you need to do the cleaning at least once, twice during every shift. So preferably twice during a 4 to 6 hour period is what is recommended. With regard to biomedical waste cleaning, it is biomedical waste. It is the same as what is recommended for the current practice. The color-coded bin should be used. Please remember, the government is now recommending even smaller clinics, even single doctor clinics, to adhere to the biomedical waste concept and have these color-coded bins. You can outsource your biomedical waste disposal to the various agencies. Next slide. Air conditioning, there are very nice recommendations given, but this may not be always practical. 24 to 30 degrees with a humidification of 40 to 70% is what is recommended. But in the summer peak in several cities, this may not be feasible. But please remember that it is directly from the patient, one patient to another, which is the reason for maximum spread, and fomites play a very, very small part in transmission of infections. Next slide. So last take-home messages. Always prefer telephonic appointments or online consultation. Restrict the OPD time to limited hours. Avoid walk-in patients. Restrict attenders. Encourage hand hygiene. Improve or educate the patients by signages. Maintain physical distancing. Have a protocol for disinfection, and avoid nebulization. So please remember, by adhering to these simple things, we can ensure that both healthcare workers and patients stay safe. Thank you. This is the last slide. We need to learn to live with Corona. Thank you. So I apologize for the confusion because there was some technical glitch here. I'm not going to take any questions here. So I'm going to invite now Dr. Surabhi Madan, who's going to talk to us about N95 as a preferred mask for use during times of Corona. Over to you, Surabhi.
Hello, everyone. First of all, I thank CIDS for giving me this opportunity. I'll start sharing my screen. Is it visible, the screen?
Yes, yes.
Okay. So I'm going to speak for N95 mask. I don't think the debate is about N95 being used in the community or in the healthcare setups. The debate is not about using N95 or surgical mask during the aerosolization. The debate is using N95 or surgical masks in other areas, which is a gray zone. So the face masks have become an emblem of a battle against COVID-19. And the purpose of a mask is the protection of the wearer and protection of the people in the vicinity. Now, an ideal mask gives 100% protection to the wearer as well as to the community. And the choice of mask, as Dr. Ram Subramaniam already mentioned, depends on the route of transmission, nature and degree of exposure, resource settings, and all logistical issues. Now, by and large, what we talk about, the different types of masks are surgical masks, N95 masks, and cloth masks. Now, till now, we have not seen N95 masks in use more than what we are seeing now. The governments and high courts, they are involved in pricing and capping on the N95 mask. The doctors and nursings are going on strike because of the unavailability of N95 masks. So we know why is it so important? Actually, it is not a mask, it is a respiratory protective device which tightly fits and seals off the wearer's face. N stands for not resistant to oil, which means that it has to be free of the oil particulate matter before it can be used. It blocks 95% of the aerosolized particles with diameter more than 0.3 microns. And It is a part of American classification and it's comparable to the FFP2, that is the filtering phase piece respirator 2 in the European classification system. It is made of electrostatic non-woven polypropylene fiber. So my talk will be outlined in 3 parts: the experimental models, the guidelines, and if there are any randomized controlled trials or not when we compare these 2 masks, that is N95 and surgical mask. Now, this is a very good article where they have compared the N95 mask and the surgical mask in the experimental model by using the sodium chloride particles and MS virus. And they have seen that the penetration of these particles through a certified N95 mask cannot exceed 5% in the experimental models. And the efficiency of the mask, N95 mask, which is calculated as E is equal to 100% minus P, must be at least 95%. On the other hand, when we talk about the surgical mask, the particulate filtration efficiency, that is the PFE, is defined as the percentage of monodispersed non-neutralized latex particles that do not pass through the face mask at a specific inhalation flow rate. Now, surgical masks have proved to vary widely in filtration capability, allowing penetration of aerosol particles ranging from 4 to 90%. These masks are open on the sides, top, and bottom, may be useful in source control when worn by a patient. But even then, there is evidence that the material escapes around the mask's margin after a sneeze or a forcible cough. And as you can see here, when we talk about the low load conditions and the high load workload conditions where the inhalation flow differs, the penetration, which is defined by the concentration of the virus on the inside of the mask to the concentration of the virus on the outer surface of the mask, that is least when we talk about the N95 masks. It is just 0.004 and 0.22. On the other hand, as you can see here, when we talk about the surgical mask, the penetration is very poor as compared to the N95s. So the efficiency of surgical mask is much lower than that of the N95 mask in the experimental models. So it should be noted that surgical masks are primarily designed to protect the environment from the wearer, whereas the respirators are supposed to protect the wearer from the environment. And as we all know, why they are called surgical masks is because they were, for the first time, they were used to protect the patient's wound in the OT from the droplets coming out from the surgeon's mouth. Now, how do we extrapolate this to SARS-CoV-2? So we know that the route of transmission in SARS-CoV-2 is mainly droplets, yes, because when the person who is suffering from COVID-19, when he speaks, coughs, or sneezes, then the droplets coming out from his mouth are directly deposited on the mucosa in the person's mucosa who is in the vicinity, or from the contaminated surfaces. However, we have more and more data which shows that aerosols, that is particles which are less than 5 microns in size containing the infectious virus, also may be a strong mode in transmission of COVID-19 from person to person. So this is a study which came out in NEJM, and it provides the visual evidence of speech-generated droplets and qualitatively describes the effect of a damp cloth cover over the mouth to curb the emission of droplets. So these are the various droplets, varying size of droplets, which exit from the patient's mouth when he speaks. What I want to emphasize here is, even in between the period, between the 2 points when the patient is speaking, as you can see here, the flash count, that is the presence of the particles in the atmosphere, is always more. It is more as compared to the background score. So what does that mean is, the act of speaking generates oral fluid droplets harboring infectious viral particles that vary widely in size, and small droplets can actually dehydrate and linger as droplet nuclei in the air, where they behave like an aerosol and thereby expand the spatial extent of emitted infectious particles. Similarly, this is another article from NEJM, where they have evaluated the stability of SARS-CoV-2 and SARS-CoV-1 in aerosols and on various inanimate surfaces, and estimated their decay rates during a Bayesian regression model. And what they found is that SARS-CoV-2 remained viable in aerosols throughout the duration of experiment, that is a period of 3 hours, with a very minimal reduction in the infectious titer. So the large particles They remain airborne only briefly because settling down because of the gravity. However, we have to be very, very sure, we need to be very much aware that breathing and talking produce much more numerous aerosols, which are too small to settle down because of the gravity and which can be carried by air currents and dispersed by diffusion and air turbulence. And as you can see here, the droplets which are inhaled, the big droplets, they are just settling down in the upper respiratory tract. However, the aerosols, that is droplets which are less than 5 microns, they go into the lower respiratory tract and settle down there. Now, this is another study from Singapore where they have done a cross-sectional study in airborne infection isolation rooms, and they have collected around 300 samples, 245 samples from 30 isolation rooms. And of the 3 samples which were collected from the air, that is air samples, 2 of them were found positive with particle sizes around 1 to 4 microns and others more than 5 microns. Another point which they emphasize here is that there is absence of any aerosol generating procedure or intranasal oxygen supplementation here. So there is no possibility of these findings and these air samples being positive because of any iatrogenic nature. Now we see what do the guidelines say. Dr. Subramaniam also already presented our guidelines, the ministry guidelines. Now let us see what are the WHO recommendations. So the WHO advocates use of surgical masks unless aerosol generating procedures are conducted. However, we must remember that the reference studies which are cited by WHO to corroborate this statement have not ruled out the hypothesis of airborne transmission of COVID-19. And in one analysis amongst these references, up to 73% of the patients reported having had no contact with any person with respiratory symptoms or exposure to relevant contaminated areas, which may be possible because of the aerosolized transmission of COVID-19. Another analysis involving patients in the airborne isolation rooms showed that air outlet fans located high on the wall behind the bed of one patient were contaminated with SARS-CoV-2, which again suggests that virus-laden aerosols produced by the isolated patient were displaced by airflow and deposited on the vents, again pointing towards the transmission by the aerosols. Now, what does CDC recommend? CDC says that when caring for patients in any area, caring for COVID-19 patients, the healthcare personnel should continue to wear the recommended personal protective equipment. And they have mentioned N95 as the only mask which should be worn by the healthcare workers when they are caring for COVID-19 patients. Now, why are healthcare workers at high risk as compared to the community people? Because they are a lethal, they are a totally different high-risk group because of the repeated exposures, prolonged exposures, and of course, lack of appropriate administrative and engineering controls in hospitals. So N95 mask is really a boon for healthcare workers whenever they are working in those areas like there are no negative pressure rooms in the hospitals and other issues. Now, are there any randomized trials? Yes. So this is a trial from China of about 1,669 patients where they had tested 3 arms, compared 3 arms, medical mask, targeted N95 use only in patients with aerosol generating procedures, and continuous N95 use. So the outcomes which they studied were clinical respiratory illness and laboratory confirmed respiratory pathogens in symptomatic subjects. And what they found is that there was a significant protective efficacy of continuous use of N95 compared with the targeted use and the medical mask, despite significantly poorer adherence in the continuous use N95 arm. And as you can see here, when we talk about the clinical respiratory infection, the percentage in medical arm is around 17%. In the target N95 arm is 11%. On the other hand, in the N95 continuous use arm is just 7%. And also benefit of N95 persisted after adjusting for the potential confounding by influenza vaccination and hand washing in this trial. Similarly, this is another trial from China where a cluster of 1,441 healthcare workers were studied. The two arms were this arm with medical mask and the N95 respirators, fit tested and not fit tested. Another interesting thing in this trial is that they included a convenience no mask group of 481 healthcare workers from 9 hospitals, which were not actually randomized, but they studied them in studying this in the subgroup analysis and secondary outcomes. Now, the primary outcomes, that is the clinical respiratory infection and influenza-like illness and lab-confirmed respiratory virus infection and influenza, were consistently lower for the N95 group as compared to the medical mask in this trial again. Another thing which was interesting was that there was no superiority of medical masks over the controls. By controls, I mean this convenience no mask group of 481 healthcare workers. So this is a very good article which came out very recently by the doctors from Hinduja Hospital. All of us should read it. Very good, concise summary about all the masks. And now a quick review between the differences, surgical mask and N95 respirator. So the surgical mask is cleared by US FDA. N95 is an NIOSH evaluated, tested and approved respirator. Now the intended use and purpose. Basically, surgical mask is fluid resistant and provides the wearer protection against large droplets, splashes or sprays of bodily or other hazardous fluids. It protects the patient from the wearer's respiratory emissions. Basically, that is its main use. It is a loose fitting mask. There is no fit test or seal check which can be done in this mask. It does not provide the wearer with a reliable level of protection from inhaling smaller airborne particles and is not considered respiratory protection at all. And leakage is bound to happen around the edge of the mask when the user inhales. On the other hand, when we talk about N95 mask, it reduces the wearer's exposure to particles, including small particle aerosols and large droplets, though only non-oil aerosols, as I already mentioned. It is a tight-fitting mask, and a fit test and a seal check should be done before donning it. It filters out at least 95% of the airborne particles, including large and small particles. And when properly fitted and donned, there is minimal leakage which occurs around the edges of the respirator when the user inhales. So, concludingly, surgical masks are ineffective in blocking particles which are less than 100 microns in diameter. Now, when and where to wear N95 mask? Dr. Ram Subramaniam has already discussed in detail. So not in the community and during all aerosol generating procedures, but in the hospitals, when we are talking about the COVID areas, it should be worn in each and every part of the COVID area, whether it is flu corner or it is fever clinic, it is the OPD of the physician, of the ENT physician or the ophthalmologist or the dentist, wards with suspected or confirmed patients, the emergency rooms and all the ICUs. In non-COVID areas of the hospital, yes, we can triage and we can include only those areas which are at high risk for N95 mask. So concludingly, surgical masks have suboptimal efficacy in hospital settings. Healthcare workers exposed to COVID-19 patients should use N95 masks in all the areas. Identification of aerosol generating procedures may be suboptimal actually. Recognizing all of them is must. For example, CPR. But I always wonder when a patient lands up to need CPR, how would we go to change our triple layer mask to N95? Do we really have time at that point of time? And lastly, supply concentrations should not supersede the safety concerns for the healthcare workers. That will be all. Thank you.
Thank you very much, Surabhi. I am going to now invite Vinay for his deliberations.
Right, so is my screen visible?
Yeah, go on.
Thank you, sir. Thank you, CIDS, and thanks, Dr. Nambi, for giving me this opportunity. So after the profound pitch for N95 that Dr. Surabhi Madan has made, I'm all the more convinced now that N95 is probably the most important commodity and essentiality on earth, more important than probably elimination of hunger or world peace altogether. So for me, it's a tall order to say how the poor cousin of N95 medical mask is still trustworthy and it still has it in it to save the healthcare worker from any respiratory infection. but I'll try my level best. So during the course of my talk, what you'll see is I'll try to scientifically analyze and dissect evidence with pragmatic application of logic and try to see whether I can change your belief, perception, and assumptions about the surgical mask and prove that surgical mask still has a role to play. So before I start, I don't have any conflict of interest to declare. Definitely not sponsored by the surgical mask. You know how poor they are at this point of time. And as you go on during this talk, you'll realize my brand is humor. Humor might prick some, but it is purely non-intentional. It is scientific, trust me. So these are the words you'll listen more and more during the course of my talk, and it will be tempered with some bit of cost effectiveness analysis as well. Before we go into the pitch for mask, I'll start with some basics about so-called droplet aerosols. There is a lot of confusion about what defines a droplet or what defines an aerosol. If you dig more and more into the literature, the magic number of 5 is always conflicting. So bulk of researchers feel it is not 5, it is 10, some feel it is 100, but we now have stopped to believe it is 5 micron, above which it's called as droplet, which are larger in size and they drop down faster. Whereas those which are smaller than 5 micron are called aerosols or droplet nuclei, which remain suspended in the environment or can be shaken up and remain in the environment for about 3 to 5 hours. Now, contrary to the popular belief that as soon as you cough, sneeze, or talk, and if you're COVID positive, you'll spray a lot of aerosols into the environment. That is not entirely true. Multiple studies have clearly proven that droplets do come out, yes, but the amount of aerosolization that happens with these procedures is minimal. Even when they come out, more the size of the droplet, greater the chance that they drop down faster and they do not survive in the environment. Even if it is aerosolization, if you can take care of the environmental engineering control, wherein you have good number of air exchanges per hour. I'll talk about that in detail in a bit. If you have good air exchanges per hour, the droplet or aerosol, however small it is, will drop down faster, as it is depicted in this study in a counterclockwise manner. So the basic science, what you need to understand, what Dr. Surabhi Madan also projected is, bulk of studies that we have about efficacy of masks in protection against clinical respiratory illness or influenza-like illness is extrapolation of studies from influenza or laboratory studies. And till all these viruses behave the same till they reach the respiratory tract. That is the other coronaviruses, the influenza virus, till they come in contact with the host, the way they enter the host is very similar. Their interaction with the host and the host immune response is what changes things thereafter. So scientific analysis recommendation from the World Health Organization and CDC with all its flip-flops have finally said that methodical application of these 5 measures is the most important mode of preventing infection of the healthcare worker managing any respiratory illness, of which ensuring triage, segregation, and patient placement with control of infection at the source, along with environmental and engineering controls, are the 2 most important mechanisms, and then come the PPE and the masks. So what that essentially means, if you have a patient who is a strong suspect or a COVID positive person, 1, you ensure physical distancing between the healthcare worker and the patient. Now remember, we are talking about the zones where there is no aerosolization. Mere cough, mere sneezing, or talking loud does not amount to aerosolizing procedure. We're talking about all rest of areas, non-ICU, non-emergency, and non-OR. So if you can ensure good physical distancing and create a barrier at each end, mask the patient, mask the healthcare worker, and buffer the entire zone with good engineering control, these are the most important mechanisms by which you can protect the healthcare worker. The guidelines, which Dr. VRS also projected, the ISHRAE guidelines, well adapted by CDC, is very clear. It defines each zone, each room of the hospital, how much air exchanges per hour are required. If you place a patient with a good ventilatory system, wherein you open the window and then there is a natural ventilation or an exhaust, or a room with inbuilt AC, which has good FCUs with clear-cut air exchanges as demonstrated by CDC, you can take care of the patient infection at source. On top of it, what we know all through, that if you can mask the patient with a surgical mask, you can prevent or reduce the number of droplets or aerosols that come out of symptomatic patients. This trial, which came about just recently and published in May 2020, took symptomatic patients. This is not a laboratory study, but this is cover of symptomatic patients. These were other coronaviruses, but like we discussed previously, the coronaviruses and influenza virus in the environment behave the same, irrespective of the doubt about aerosolization and then droplet transmission. If you put a mask to the patient, the extent of droplet or aerosol coming out significantly comes down. So patient source control and engineering control are the two most important things. But why is there such a stress on PPE and mask? Not that they are wrong, but why is there so much stress? And it is believed that PPE and mask are the most important things. Why is that? Probably it has got to do with perception. So what we saw in the initial few months was the images coming out of China and from the West, where the healthcare workers are battered by prolonged use of N95. People didn't see anything else. These were healthcare workers in the critical care zone. So what people observed was the use of N95, and N95 probably became the symbol of healthcare worker resilience. And when symbolism takes over, science takes a stumping. Back to science now, there are clear-cut guidelines about masks from the WHO, from CDC, with heavily borrowed content from the National Institute of Occupational Safety and Health. It clearly says, in a zone where there is no aerosol generating procedure, you go for the triple ply mask or so-called surgical mask and medical mask, and you need the FFRs, the filtering respirators, only in the aerosol generating procedure. Now the bulk of argument is probably there is aerosolization of coronavirus and that explains the spread, but this theory is yet to be proved. Even if there is aerosolization, this is the assumption that people have, that we are constantly covered by a hazy cloud of coronavirus all around us, and they want to cover themselves in all aspects. This was the level of obsession observed by the healthcare workers, purely based on perception, no proven science. Precaution is good, but this is not proven science. The obsession has come down and now the focus is entirely on masks. So with the focus being entirely on masks, the question to be answered is, are the triple ply masks or the surgical masks inferior to the respirators or the N95? In an aerosol generating area, I completely agree with the recommendations and with Dr. Surabhi that it is N95 which clearly scores over the triple layer mask. But in a non-aerosolizing procedure area, like the OPD, outside the ER, outside a patient care room, I do not, even if it's a COVID area, I do not believe that N95 should be generalized at all. Is there literature to back my claim? Yes, I'm not going in for any laboratory study. I'm going in for in-field clinical analysis, meta-analysis of lot of randomized controlled trials, and also of case control studies has clearly shown that for bacterial respiratory infections, N95 clearly scores over the surgical mask or the medical mask. But when it comes to influenza or any such influenza-like illness, there is no statistically significant difference. Even the so-called Chinese study, which Dr. Surabhi projected from Chandaraina McIntyre, clearly didn't show that N95 was statistically more significant in protecting the healthcare workers when compared to surgical masks. If you say 5 is more than 3, that's why it's important. No, sir, it is not. In such a large group of population, you should show statistical significance, and N95 does not have it. This well-designed randomized clinical trial in a clinical setting done in the US from 2011 to 15 and published in 2019 also shows the same effect. People, healthcare workers who are placed in high-risk zones outside the ER, OP rooms, pediatric OPs, and in adjacent influenza areas in the season of influenza, if they wore the surgical mask in a proper methodical way and followed all infection control precautions, the rate of infection with influenza or influenza-like illness was not significantly higher compared to N95 mask at all. So surgical mask still has its relevance. 10 years ago or 11 years ago, Lieb in Canada proved the same, and bulk of meta-analysis have also proved that there is no statistically significant difference between surgical mask and the N95 mask when it comes to protecting the healthcare worker from respiratory infection. For all the talk of influenza also aerosolizing, corona also aerosolizing, these are years and years of data in a clinical specimen and also on laboratory platform, which has clearly shown that N95 is slightly good. But when it comes to non-aerosolizing areas, surgical mask does not fare bad at all. So that answers my question. Yes, in non-aerosolizing areas, triple ply mask is good enough and you should not generalize N95. Going beyond science, let's look at some logic as well. For any PPE, particularly for mask to be useful, you should be using it efficiently and effectively and consistently. So what do you look for when you have to use something consistently? You look for comfort first. When you're clearly proven that the surgical mask in a non-aerosolizing zone provides the same degree of protection as N95, if not more, Why do you want to compromise on comfort? Because compromising comfort is compromising safety. You'll fiddle with your N95 at some point of time, then touch it, forget to do hand hygiene, and then spread infection everywhere. That is bound to happen in the long run. Now, there is more and more focus on the surgical mask being clubbed along with face shield, which enhances the level of protection. For all the talk which is going on about the filtration efficiency of the surgical mask and N95 being better, this added on, and if we diligently look into it, definitely will have the same degree of benefit. Many centers have already adapted it and are following it. Same logic applies to ease of donning and doffing of a surgical mask in comparison to N95. This is where N95 most mistakes happen, and it is a recipe for disaster if it's used for a longer time. Then let's look at the cost effectiveness. This, we are in for a long haul. This is not going to end in 1 week, 1 month, or 2 months. This is going to go on for many months or maybe a year, if not less. What we need to realize is these are essential commodities which have to be discarded after each patient use. A good NEOS certified N95 mask costs in the range of 300 plus. If you're repeatedly discarding some material, you're not adding to the benefit of cost for your institution at all. Let's say you have adequate money, you'll reuse it. The disinfectant procedure which we are talking about and the reuse is not well validated at all. So you're keeping it outside, using it after 5 days. With the moisture, with this heat which you're using, the effectiveness of the mask is still doubtful. So it is not 100% foolproof procedure. So when you go to N95 mask with such a great demand, the demand entirely shift towards N95. People will get obsessed with N95. It will create a huge demand, and there is a gap in demand supply chain. People will stop manufacturing surgical masks. Once we realize all the N95 that we have with a huge number and the counterfeit that follows, that is duplication that follows, we will have to come back to surgical mask, and at that time there may be no manufacturers at all. We may end up wearing all type of native masks which may not provide us any benefit. So with the requirement of consistent and effective use, it is prudent that you go for a mask which is comfortable, which is cost effective, and the surgical mask clearly scores over. I will not go into detail of how to choose a surgical mask. A lot of details available on the net. What I would like to end my talk is by saying that creating a good engineering control, controlling the infection at source, are the most important infection control measures protecting the healthcare worker. And then you concentrate on PPE and the masks in general. And in non-aerosolizing areas, triple ply mask still has a great role to play. Now, all what I said, all what I analyzed, all the extrapolated data will become valid only when good clinical randomized trials are done. Now, with all the important publishers having this publication anxiety and going in for premature publication, it is resulting in unsatisfactory results. I think we should use this opportunity to see one-on-one how N95 fares against surgical masks. And I'm pretty sure at the end of it, the question will be answered, and my belief will be strengthened that medical mask still has it. It is still trustworthy, and it has a job to do. It can be used in non-aerosolizing areas. I'm not for generalizing N95 at all. So with this, I'll end my talk, and I'll see you on the other end during counter argument.
Thank you very much, Dr. Vinay. I think that was a very interesting tussle. I'm going to now call Surabhi back for a couple of minutes. I think we are running a little short of time. So I'm going to ask them to be a little brief. 2 minutes for you, Surabhi.
Hi, so Vinay, a very wonderful presentation, though it was not supported by any scientific studies much. It was more of a pragmatic, dogmatic talk. So I would start here with that absence of evidence because of the trials does not mean the evidence of absence of the benefit of N95. Okay. And as you mentioned that, there is no aerosolizations when the patients comes to us in the OPD. How do we know? There are more of, I always showed in my presentation the video analysis and all that stuff. See, we have to wait for the randomized trials, but right now we have to do with whatever data we have. And it clearly shows that if the people are coughing loud, breathing, they are even exhaling loudly, and they are speaking loudly, there is some amount of aerosolization that happens. Now, engineering and measures which you talked about, they are definitely important, but overnight we cannot change the architecture and the infrastructure of the hospital. And believe me, we have tried our best, but I don't have negative pressure rooms, air exchanges, proper ventilations in all my rooms where my COVID patients are admitted right now. 130 patients in the hospital at present. So that is another point. Now, WHO recommendations are always based on the resource limiting settings. In my hospital, luckily ours is a tertiary care center where budget is not much an issue. So we are, for last 2 months, we are catering to the patients with COVID-19 wearing N95 mask in all the areas in the COVID area of the hospital, whether it is OPD, whether it is ward, whether it is ICU or it is ER. Now, reusing the masks, as you said, we are reusing, and we are reusing one mask 4 times, and the effectiveness has been proved by CDC London. You would already know that. And if we reuse the mask, then the cost does not, the cost comes down to somewhere a difference of just 12 to 13 rupees. So not much of a difference between surgical mask, which has to be by default disposed after a single use. On the other hand, we are using N95 masks for at least 4 times. And in the last 2 months, we did not have a single healthcare worker getting infected from the COVID area. We do have healthcare workers who have got infections, but they have got it from their hot red zones and hot zones where they live, from the community. Again, the meta-analysis which you presented, that you should know that the trials which were included in that meta-analysis were very underpowered. The number of patients which were included in those trials, separate trials, were less. The studies were less, of the number around 400 to 500. And also, if you see that low betals trial, which in 2009, which came up, and all the policies which were made up on that, based on that trial, that was a very underpowered trial, and they used the antibodies, influenza antibodies, as a clinical outcome, and the positivity in the healthcare workers, and the exposure and the infection was of the around 24%. That was very high in both the arms in that trial. So that meta-analysis is poor quality, because the trials itself themselves are the poor quality trials. Now, I don't buy your points on the comfort, because safety is always above comfort. I don't care about the marks which I get on my face. I'm least worried about them. Again, if you talk about the shield, I'm least comfortable with the shield when I wear it, because there is a lot of fogging which happens in the round. I have to ultimately remove the goggles and the shield, whatever I'm wearing. And again, these shields also, the different kinds of shields are available. So fogging is definitely an issue. Now, talking about the duplication of the masks, yes, we have to be very careful about that, about the poor quality N95 mask. So in our hospital, we have 3M masks which are present. No other company is allowed. And if we talk about the cost of that, it comes to somewhere around 30 rupees per mask if I reuse the mask around 4 times. That is all from my side. Thanks.
Thank you, Surabhi. Another 2 minutes for you. Make it brief, Vinay.
You unmute yourself.
So, is it visible right now?
Yeah, I think you just need to, yeah.
Almost to counter your claim that this is not based, well-powered studies. This study, which came in 2009, had good number. It was a randomized pragmatic clinical trial. It clearly showed that N95 was non-inferior to the, surgical mask was non-inferior to the N95 mask in a clinical setting, not in a laboratory-based study. Second thing about engineering control, it doesn't essentially mean you need negative pressure room. It can be a room which has a split AC also, but you need to ensure there is more air exchange per hour. It is a simple, easily doable procedure. Not much of cost goes into it, that our engineers will be able to tell. About fogging, if you're wearing a face shield and then it fogs, then it essentially means that your fit test is not adequate at all. So if you're not doing a good fit test, then the face shield will definitely fog. Now, coming back to my actual counter argument, my counter argument is based on N95 being generalized, anti-N95 being generalized at all. Much hangs in balance. So I'll go through definite and specific reasons. One, not everybody is an expert like Dr. Surabhi. Not everybody knows how to wear it. In spite of repeated video trials, in spite of repeated teaching, not many people know how to wear it. So this compromises the safety of the healthcare worker. Not everybody is fit to wear it. Somebody with facial deformity or some issues with the face, somebody with a beard cannot wear N95 at all. We need to look at it in a broader perspective. So if they cannot wear it, then they cannot fit it. not many people, I would say not many, most of the people do not know how to do a fit test. Every time you get a new lot of N95, every time you wear a new N95 mask, you fiddle, remove it, put it back, you have to do a fit test. And not everyone is aware, not everyone is capable of doing a proper fit test. So that is my dispute against N95, that if you do not do it well, you're not using it well at all. And that means your face shield is fogging, your fit test is incomplete. Then N95 was not meant for long-term use at all. Constantly, like I said, there may be very few driven people like you who can wear the N95 and last for a longer time. But trust me, I mean, experience has clearly shown that people do not last longer in N95. They take it off and then again compromise. Compromise in safety does happen because of lack of comfort. You see very few people who are driven enough to wear N95 for longer duration of time. Counterfeits have taken over. Like I said initially, if the demand increases, the duplicates come in. Not every mask is well regulated. Not every mask is well tested. What you might be wearing actually might be a duplicate N95. It's a very difficult process to identify what is duplicate and what is not, and you may be wearing a duplicate one. Second thing is this reusable strategy wherein you put a surgical mask on N95 came in because there were mask shortages during the 2003 pandemic of SARS. This is not clearly validated. This is more of a precaution. This does not have any confounding scientific basis at all. This study very clearly dissected how in given scenario with humidity, respiratory issues, heat, and the infection risk, wearing this is not a long-term solution at all. But unfortunately, the same researcher did a very underpowered trial of 10 patients or 10 healthy people and then reversed this finding. So what I feel, putting on a surgical mask on an N95 is akin to removing Superman's mojo. You're not allowing N95 to do its job. You're suffocating the healthcare worker. And then the surgical mask is just sitting on top of it and not serving its purpose at all. And the reuse strategy where you're disinfecting, it is not completely well validated. CDC has approved it, yes, but not many trust the CDC completely nowadays, a lot of flip-flops. So if you're reusing it after disinfection, you still don't know what is the validity. You just can't say my healthcare workers were not infected. For that reason, N95 reuse after disinfection is a good policy. It is akin to going into a war with only a life vest. I do not ascribe to N95 being completely foolproof. There are enough trials, there are enough studies to show in a clinical level of work in non-aerosolizing areas, triple ply mask is as good as N95. These are clinical data. And given all the drawbacks of N95, let me go out and say maybe N95 is at risk. It may be taken over by respirator and then the surgical mask will remain. Generalization of N95 is not an acceptable strategy for all the negatives that I just put forth. Thank you.
Thank you very much, Vinay. That was a very interesting sparring between the two of you. In the usual scenario, the moderator will ask for a show of hands from the audience to decide, who's won the debate. But unfortunately, I'm not in a position to do that. But I think what I glean from this is, in an ideal situation, yes, N95, assuming it is fit tested, assuming that the person knows how to wear it, assuming that you have a good supply of masks or cost enough to go for the mask, and if you're reusing, assuming that the validation is appropriately done, is probably better, of course. But in a practical situation where we have shortage of masks, where we have problems with fit testing, where we have problems with reusing and validation, where most of our healthcare workers unfortunately don't use the masks appropriately. I've seen people in my hospital where we pride ourselves in educating our staff workers, where a surgical mask on top of which they have worn an N95 mask. So when all these happens and you cannot ensure that the person is adequately protected, I always have sort of concerns about N95, people thinking that N95 is good and going on improperly wearing it. So for all these reasons, I have a little bit of a concern about N95, even though probably N95 is superior in situations. So if you're looking at comfort, if you're looking at practicalities, at least in most situations where you don't have aerosol generating procedures done, I think a 3-ply surgical or a medical mask would suffice. So I think there are pros and cons against both, but this is what I would leave as a parting message. Now I'm going to ask Dr. Nambi whether there are about 7 to 8 questions. Do I take on these questions over the next couple of minutes? What do you say?
I think we can take a couple of questions. I'm not sure. People are interested in knowing about the disinfection, all those things. A few of the probably the fogging in OP. please take those questions. We'll finish off.
I will quickly run through the questions asked as one. What about the role of UV light or hydrogen peroxide vapor in the OP clinic? One, they are expensive. The UV light, which is available as a simple light, cannot be used when people are around. It has to be used when nobody is around. But please remember, none of these will work unless you thoroughly clean the organic matter or you clean the surface. So if you're going to clean the surface with a proper bleach solution after appropriate contact time, a UV light or a hydrogen peroxide vapor is not necessary. The cleaning alone would do. You don't need to spend additional. And if you use a UV light, which is a single lamp source, whether it will penetrate into all areas of the clinic, you have questions. So I don't routinely recommend that. Two, role of auxiliary temperature. Yes, ideally, even though thermal guns, as I said, are useful, they may not be very sensitive. So auxiliary or oral temperature, if it is possible, at least in strongly suspected cases, is what I would recommend. You can always disinfect the. Three, what type of a gown? Should use a linen, an impervious gown, or what? There is a Cochrane analysis which has looked and said that most people favor a breathable gown. Any impervious gown is probably very uncomfortable. And the same thing goes for somebody who's asked, can we use a raincoat and a helmet? Where, you know, if there is cost constraints, using a raincoat and a helmet, no, they are very uncomfortable for more than 15 minutes in a closed space. So I wouldn't recommend that. And as I told you earlier, when somebody is uncomfortable, he's unlikely to perform effectively and also adhere to infection controls effectively. Pulmonary function test, I forgot to mention, pulmonary, the disinfection, the PPE, all should be geared towards aerosol generating procedures. Use of plastic apron and a face shield. Yes, but make sure that the plastic apron should cover your hands also. You cannot wear only a plastic apron in front, which is not allergic. And lastly, one question which I don't know about, a couple of people have asked about the Kavach mask, which is come out by IIT Delhi. So if Surabhi or Vinay, if you have an answer, I haven't seen or heard about the Kavach mask. Do you know? What about you, Nambi? Kavach mask, I don't know what it is. IIT Delhi.
I do not know. Probably we can answer the sender because the sender is a little upset that we have not answered that question. So from the same person, the question has come thrice. Probably we'll answer that question tomorrow.
Yeah, and lastly about fogging, no, I don't believe routine in fogging. As I said, as long as you do a thorough terminal cleaning manually, that is good enough. One of the thing is goggles. How do you disinfect? Good old soap and water and cleaning it is more than adequate for reusable goggles. I think those are most of the questions I have tried to answer. I now thank you very much. I think both of you did an excellent job. Thank you, Surabhi. I think you brought out all the scientific aspects, and Vinay, you trying to punch holes in all her science and say what is practical and what I really enjoyed the last 6 points you raised. So thank you very much. I now hand over to Dr. Nambi.
Thank you, viewers, and I thank Dr. Ram Subramaniam for moderating the session, and then I thank Dr. Surabhi for putting an excellent scientific analysis. Again, when I knew that he's one who can pepper his talk with both science and humor, and then he did it very well. And then this is the first debate that we've had, the CIDS webinar series. I thank both Vinay and Surabhi for joining in a very short notice. Probably I called them this Monday and then asked them, look, let's get it done on Friday, and they were very, very quick to respond. Thanks a lot for accepting and then doing it in a very nice way. And thank you, viewers, for joining in today. And people who have joined in late, or people who want to see the action again, please log into www.citsindia.org, or you could go to the YouTube and type in CIDS webinar. And tomorrow again, we have a debate on PCR. Should it be an universal PCR prior to all invasive procedures, especially surgeries? And then or should be targeted testing? And then the most important question right now is, how do I make the operation theaters, the ORs, safe from COVID? And for that, we have Dr. O.C. Abraham. And for the debate, we have Dr. Swati again from Ahmedabad and Dr. Vikas from Delhi. And see you all tomorrow. Bye-bye. Take care. Goodbye.